We'll let everybody get situated and make sure that your video is working and that your audio is working. Thank you, everyone. Good morning. Thanks for joining us. We do have a great agenda today. And Sandeep Patel and I are going to be hosting and moderating our panel discussions, and we have some great talks. So to start out with, we have some introductions. Is everybody on?
Yeah, it looks like Julia just joined us as well, and Akash. So I think we have quorum, Tiziana.
Awesome. So welcome everyone for our meeting today, OncTalk 2022. And I'd like to introduce Dr. Patel, my co-host and co-moderator today. Dr. Patel is a professor at UCSD and a medical oncologist focusing on early phase clinical trials of immunotherapy and thoracic oncology. He's a leader for the Experimental Therapeutics Phase 1 program and deputy director for the Center for Precision Immunotherapy at UCSD. He's also the director of the Clinical Trials Office at UCSD and co-leader of the NRG Developmental Therapeutics Committee, as well as co-leader of the University of California Lung Cancer Consortium.
Thank you so much, Tiziana, and it's my pleasure to be introducing my co-host, Dr. Leal, who's an associate professor and a director of the Thoracic Medical Oncology program in the Department of Hematology and Medical Oncology at the Emory University School of Medicine. She serves as a member of the board of directors for the Georgia Society of Clinical Oncology and is board certified in both medical oncology and palliative care. Dr. Leal specializes in caring for patients with lung cancer, mesothelioma, and thymic malignancies at the Winship Cancer Institute in Atlanta. Dr. Leal's clinical research focuses on clinical trials of chemotherapy and immunotherapy to treat cancers of the lung. And really, without further ado, I want to introduce, as we introduce to speak, our amazing OncTalk faculty, really a group of leaders in the field representing a variety of different specialties and expertises, and none better suited than Dr. Leal herself. And so with that, I'd like to introduce our first speaker, Dr. Akash Desai. Akash Desai is an associate professor of medicine at Mayo Clinic in Rochester and is a former patient ambassador for GRACE and is a member of the career development community for ISLAC, as well as an ISLAC Early Career Award member and Conquer Cancer Foundation Award member.
Oh, I think I may be going first, Sandeep.
Oh, sorry, Dr. Angar. Dr. Angar is an associate professor and vice chair of strategy program development in the Department of Radiation Oncology at UT Southwestern and is co-leader of the thoracic program at Simmons Comprehensive Cancer Center.
Great. Thanks a lot, Dr. Patel, for the introduction. Let me share my screen. Hope everyone can see that. I'll do that in, and then we'll switch modes. There we go. All right. Well, it's an honor to be part of this very exciting panel, and I really thank everybody for the opportunity to speak today. I wanted to talk about something that's near and dear to my heart, and it's the idea of the utilization of local treatment, be it radiation, surgery, or any other modality in the management of metastatic patients. And the real idea is, are we trying to identify, or can we identify a subset of patients who will actually benefit from local therapies, not just for palliation, but actually for survival benefits? These are my disclosures. And so, as we all know, at the end of the day, as we try to personalize our therapies to optimize treatment of our metastatic non-small cell lung cancer patients, biology is really the prime driver. And as you can see from this laundry list of things, we are getting a much better understanding of the biology of non-small cell lung cancer and realize that it's a very heterogeneous disease. But one of the things that I wanted to bring up that's in red is that whether we can determine and use the idea of patients who only met out in limited number of sites versus those who met out more widely as another biologic surrogate for us to be potentially aggressive or use a different treatment paradigm. Why is all of this even possible? This is all possible because of the great work that has been conducted by our medical oncology colleagues to improve systemic therapies. So clearly, the introduction and utilization of immunotherapy with or without chemotherapy has improved our outcomes, but clearly we can do more because the curves can get much better with respect to progression-free survival and overall survival. But without a good systemic therapy, there would really be no role for local therapy. And so that's really the rationale for the use of local treatments, local again being radiation, surgery, ablation, for the treatment of metastatic disease. Systemic therapies have gotten more widespread. They've gotten better, but they are not perfect and really cannot stand alone. And with better imaging, the question is, can we identify a subset of these patients who don't metastasize widely as a chronic or curable subset of patients? Additional rationale for using local therapy is the fact that most patients do respond to their first-line systemic therapy, whether it's chemo, immunotherapy, immunochemo. And the problem is that that's not an as durable response as we would hope. Historically, with chemotherapy, progression would occur after 3, 4, 5 months. We've certainly improved that with IO-based therapy. But the other important aspect of this is that most failures, when they do occur, and most first failures occur in sites of original gross disease. So that was known and established by the University of Colorado group a number of years ago, that the original sites of disease that a patient has at diagnosis and at recurrence, the original sites would be the sites of recurrence. But the question is, do we get a similar pattern of failure with immunotherapy? So we set out to do an experiment or study where we looked at about 118 patients who were treated with systemic therapy alone, primarily a pembrolizumab-based immunotherapy. Out of those 118 patients, 71 recurred within the period of time that we analyzed. And when we looked at the patterns of failure, what we found was that in that table 2 on the topmost part, most failures, about 84% of failures, included original sites that existed at the time of diagnosis. So again, when patients fail immunotherapy, they appear to be failing where they first had disease. And you could see the other kind of information about the pattern and the distribution of failures. But what was also very striking to us is that when you look at the third area, oligoprogression versus systemic progression, at least half the patients only failed in 3 or 5 or fewer sites of metastatic disease, whereas the other half failed more widely. So it again gave us some promise that even in the era of immunotherapy, there are a large number of patients that are not failing widely, but failing in a limited fashion, again, providing us with the impetus to consider local therapy. When you look at, and it's a small subset of patients in this retrospective analysis, but when you look at survival as a function of progression or no progression, it's very obvious. Those patients who progressed had the worst survival, and the ones who progressed the earliest had the worst survival. On the top left graph, on the top right graph, you can see that those patients with oligoprogressive disease are the ones that failed in a limited fashion, did have improved survival. We are going back and looking at those patients to see how many of them actually received local therapy and how many did not. When you look at the bottom left, patterns of failure, again, survival was worse when there was both an evidence of local and distant failure. And then at the bottom right, when you look at survival as a function of whether the failure was in a new, existing, or both disease sites, the patients that developed new failures ended up having the best survival. So again, the idea that local failures are important to control is a meaningful one. So I'm going to focus most of this talk on the consolidative setting, meaning after patients have received some systemic therapy, but before they have progressed. And the reason that I do so is the fact that we, as a non-small cell lung cancer field or as a tumor field, we have done an incredible amount of work early on with early phase clinical trials to establish that that patients that do receive local therapy and consolidation for oligometastatic non-small cell lung cancer actually do very well. So these are early phase trials with early signals that suggested to us as a group that giving radiation or doing surgery to oligometastatic disease not only improved progression-free survival, and I have 3 arrows that point to the randomized studies that showed a progression-free survival benefit for this patient population when given local therapy, but there was also an improvement in overall survival as identified by 2 of these studies that had large enough patient populations. So really, we were starting to understand over time that the use of local therapies may actually be very beneficial. And then the issue with those studies, of course, was that they were all done in the era of chemotherapy alone. And so none of those patients received immunotherapy. And so when we started to have studies, some that were done, for instance, by Baumel et al. At Penn, single arm study, and then another study by the Netherlands, when we started looking at how immunotherapy and radiation may synergize to improve outcomes, what we found was that there was a signal that was probably better than our historical outcomes with systemic therapy alone. However, that signal got muddied by a few other studies, such as this one that was done at the National Cancer Institutes, that suggested that combining immunotherapy and local therapy did not help metastatic non-small cell lung cancer patients. And the real question is, why did we not see a benefit? And the real point of the matter, which I think we're going to have to harp on over and over and over again, is that it wasn't just enough for us to decide whether a study works or not in terms of the primary endpoints. It's also for us to understand biologically why something did or did not work. So, that brings me to the point, and I'm going to pontificate a little bit in this presentation to really try to drive us to move in the directions that I think will be necessary to really optimize what we can do for the oligometastatic patient population. But, at the end of the day, none of these studies have accomplished enough to date. And the question is why? And really, it's why, because we still have a poor handle on how we should define a patient to have oligometastatic disease who would benefit from local therapy. We've used a number, a numerical value. Some of studies have used 3 METs, some have used 5 METs. I don't even know if the number of METs is relevant as much as our understanding of how patients will fail or not fail longitudinally over time. We don't have a firm handle on whether the location of METs matter. Some studies suggest that having liver Mets is more detrimental, but other studies have not demonstrated that. Does the volume or size of the metastases, if done in a limited limited number matter? And then really the question of nodal disease as part of the primary process. Is it imperative to treat the primary disease and the lymph nodes involved? Again, we're still uncertain as to sequencing. When is it the right time to give this radiation? Is it upfront at the time of diagnosis? And so that would limit the patient population to patients who had oligometastatic disease when they were diagnosed. Is it at consolidation? Would we then be able to include patients who may have had 10 or 12 METs at diagnosis, but then after their systemic therapy started, what was residual and left after 4 courses or so were 3 or 4. So, would it be only at oligoprogression when we know that the patients have done well in a majority of sites, but then at some point down the line, they fail in 1 or 2, and that local therapy may help the systemic therapy continue to keep things under control. And so really, we don't know enough about sequencing. The early studies that I demonstrated, that I presented, demonstrated that consolidation may be a very reasonable time to offer radiation. At the end of the day, we don't know what the right metric is. And I've learned a lot by running a consensus guidelines with the astro and estro and oligometastatic disease from our patient advocates, because I think, we certainly appreciate the importance of overall survival, progression-free survival, a time from metastatic disease-free survival. But what also is critically important is quality of life. What also is critically important is not just saying that a generalizable quality of life, but a quality of life is different for each independent patient. Some have different thresholds for what they view as a good or bad quality of life. And so we need to take all of that into account to determine whether local therapy benefits are actually meaningful. And ultimately, we have moved towards larger phase clinical trials, but these need to be finished. But we have to finish these with a sense of urgency. We have to understand that they have taken some time, and we need to continue to optimize getting these done. And I'm just going to point to my experience with the study that I am the PI of, LU002, to give you a sense of where we are, where we need to be, and how we can improve on what we've done. And so this is, as you would imagine, with a treatment option, local therapy synergized with systemic therapy. It's a large team made up of medical oncologists, radiation oncologists, surgeons. It's the entire multidisciplinary team that's really critical for assessing when local therapies may be of benefit. But the idea is similar to the early phase 2 studies. So we take patients with metastatic non-small cell lung cancer, give them systemic therapy. It can be immunotherapy, it could be chemotherapy, it could be combination therapy. And then after 4 courses, we make sure that there's no progression, and we make sure that the patients have 3 or fewer sites of metastatic disease beyond the brain. And then we randomize them to either maintenance systemic therapy alone, so they just continue systemic therapy, or local therapy in the form of radiation and surgery to the Mets, followed by maintenance systemic therapy. And the real question we want to understand is the addition of local therapy going to improve survival outcomes? And so this is a phase 2/3 study, which means that we've enrolled 218 out of 378 patients. And the idea is that at this moment in time, we are going to do a check to make sure that we still have a progression-free survival signal. And if we do, then we will move on to the phase 3 portion. What's critical, because I'm a big harper about biology, is that we've collected samples at registration, which is after the induction systemic therapy, after the local therapy for that arm of the study, and at first recurrence. So we'll really be able to try to understand systemically what's going on as a function of what's going on with respect to imaging and other tools to aid us determine outcomes. This study allows all forms of FDA-approved systemic therapy regimens, but it's really become a immunotherapy trial. At this slide says 80%, but at this time, more than 90% of the patients have received IO or immunotherapy-based systemic therapy. So it's really a question of whether local therapy helps immunotherapy improve our treatment outcomes. Why is it really important to finish that study? Because we had some parallel sister studies, one going on the UK, which was going to be a very important study, headlined or PI'd by my colleague, Dr. McDonald. Unfortunately, because of poor enrollment, they had to drop going from a phase 3, and now it's really a phase 2 trial. So it goes back and answers the same questions that is the same level of questions that the original studies answered. And we really need to answer this with a larger patient population. And so, we do have other studies. Omega's a similar study out of Italy. There's a study out of India looking at similar questions, but we need to complete them. The thing is, we need to complete them in a timely fashion. But it's not so simple, because as systemic therapy gets better and better, there are newer and newer first-line regimens. So we need to incorporate and account for them as we do these trials. But the real questions that are relevant to patients and the physician teams are, what if we don't have an overall survival benefit, but the progression-free survival benefit is significant? We also, mind you, have very important quality of life metrics built into these studies to better understand, how quality of life changes are occurring over the course of time. What if quality of life is very significantly improved, but the PFS benefit is limited, the OS benefit is limited? These are all the types of questions that we have to ask. And at the end of the day, as I've said, we are going to anticipate doing a lot of biology on this trial, trying to collect blood specimens to understand how the immune system is responding to the local therapies and how there may be a synergy between local and systemic therapies. We're doing radiomics to try to understand how imaging may help us predict which patients may benefit from local therapies. But again, we need to develop a greater insight and have a greater level of urgency with these trials. And I think at the end of the day, doing the phase 3 trials as a confirmatory approach is very good. But what we need to continue to do is early phase trials that give us a better biologic understanding of which patients may benefit from these treatments and which patients will not. Then by doing this, we can enrich through a biologic approach and through biomarkers, these phase 3 studies to increase the likelihood that these studies will actually give us a very strong positive reading. To that end, our systemic therapy colleagues and medical oncology colleagues have done a wonderful job of doing these basket and umbrella trials to try to capture as many patients as possible and use a standard platform to ask a number of clinical questions in a more urgent and rapid manner. I think the same can be done with systemic therapy combinations with radiation therapy as a local treatment. To answer some of the questions that I described before were unanswered, and also to get, to give us more understanding of the biology, which may inform us on the larger scale clinical trials. And so, with the right samples collected, with the right biologic questions answered, we really will be able to help understand why there are outliers in the process, why there's heterogeneity in our clinical findings. And I think that's as important as getting the right results from the trials. So at the end of the day, we need to focus on personalization, personalization, personalization. But it's not just a personalization of the tumor and the genes that are driving the tumor's behavior. It's a personalization with respect to host responses to the various therapies that we provide. So with the last remaining few slides, I want to talk about what we've learned from the oligometastatic studies that we've done and where we need to go. I think, again, using a number to decide whether a patient has oligometastatic disease is not an ideal choice, to put it mildly. I think if you look at this graph that I curved out very haphazardly in PowerPoint, you can understand the message, which is basically that at diagnosis, it may appear that you have oligometastatic disease, but once first-line therapy starts, your tumor burden systemically can go in many different directions. And just taking the initial snapshot in time to understand what is oligometastatic is really poor. We need to have probably a better biologic understanding of which patients will have microscopic or subclinical disease that may manifest more quickly versus those patients that have disease that may not manifest for a long time, for which local therapies may be helpful. All our clinical trials to date have focused on being agnostic to systemic therapy, meaning we've permitted all regimens of FDA-approved regimens on the trials to be pragmatic about keeping these studies enrolling rapidly. But the good aspect is that, yes, we will be able to enroll more rapidly, and we are permitting and having a good understanding of how all standard of care systemic therapies may synergize with local therapy. The bad aspect about that is that we may dilute out the benefit that a specific systemic therapy may have with a local therapy. And then, again, if you only prioritize one systemic therapy in the clinical trial, it may give you an easier time to interpret the data. I've already talked about number 4. oligometastatic disease that started at diagnosis and stayed oligometastatic based on purely our numerical evaluations versus a person who may have developed oligometastatic disease by numbers after induction systemic therapy. I think those two patients represent different patient populations, and as much as possible, we need to be clean about which patients that we're really including in our clinical trials. Patients with targetal mutations are a very important group, of course, but their biology is really much different. For instance, they don't respond very well to immunotherapies in the second-line setting, and so, I think it behooves us to keep those patients separate in these oligometastatic trials as we go forward. This idea of metachronous versus synchronous metastatic disease, the idea meaning when you're diagnosed, if you have metastatic disease, that's synchronous metastatic disease at the same time, versus a patient that may have had stage 1, 2, or 3 disease, was treated with local and systemic therapy, and then maybe 5 years down the line developed a single metastasis. I think it's very important that we understand that that probably represents, again, 2 different biologic spectrums and that they need to be treated differently. I can go through for number 7 over and over again a list of how many different doses and fractionations of radiation we could theoretically use to optimize the synergy with immunotherapy and dealing with disease. But I think those basket or umbrella trials that I highlighted before may give us a little bit of insight. And ultimately, 8 is really what we're aiming for. We need to identify metastatic tumor or host tissue biomarkers that are predictive and prognostic of, number 1, durable responders to systemic therapies, such that we can be more convinced that a local treatment of a local site of disease may actually be beneficial if they're responding durably to systemic therapy at other sites of disease. And then again, it goes hand in hand. It's about the same thing. Those patients that truly have oligometastatic disease so that they can maximally benefit from local therapies. And so I think I have 2 minutes, future directions. I think we need a better understanding of trial eligibility, meaning we need to enrich for those patients who we think have oligometastatic disease. And I'm going to read what I underlined because I think it's very important. And it's something that we could do, for instance, rather than the number of lesions and a strict time to start local therapy, we theoretically could follow ctDNA levels, for instance, to determine disease burden that can potentiate the development of new sites of disease. And so, for instance, if that ctDNA level is low, we may want to treat all visible mets, no matter the number, if we can do so safely and obviously, because the likelihood is there may be quite a bit of time before there's more clinically apparent disease. If the ctDNA level is high, for instance, it may suggest that the disease we're seeing by imaging is the tip of the iceberg and we should lay off the local therapy. I think trial design is very important. There are new approaches called SMART trials, for instance, that allow patients to go on study, and if they don't respond to a therapy, stay on study and get a different type of treatment. Those type of unique and innovative studies may help us do trials faster. I think real world data is very important. For instance, the UK, United Kingdom, made SBRT a standard treatment for oligometastatic disease, not based on a randomized phase 3 trial, but based on collection of data on a registry study. Could we do similar things in the US? I think it's possible. There's a lot of words on this, but I'm just going to say that we need better biologic markers of oligometastatic disease to avoid including patients with a lot of heterogeneity on these clinical trials. And we need to continue to work with our medical oncology colleagues to understand what the potential limits are of systemic therapy and to see how we can synergize with radiation, for instance. And my last slide is to say that ultimately, at the end of the day, for all our patients, we are personalizing therapy. We've done so for many different patients with many different tumor oncogenotypes. We need to do the same for patients with oligometastatic disease who could benefit from local therapy. And with that, I'll conclude and I will stop sharing. And I thank you for your attention.
Thank you. Thank you, Dr. Iyengar. We will have a panel discussion. We have some interesting questions that have come up in the Q&A. So if you have any questions, please jot them down in the Q&A and we will address those in the live panel discussion coming up. Next, it is an honor to present our next presenter, Dr. Julia Radow from the Dana-Farber Cancer Institute. She is the clinical director and a physician at the Lowe Center for Thoracic Oncology at the Dana-Farber Cancer Institute in Boston. She's also an instructor of medicine at Harvard, and her talk will be about chemoimmunotherapy strategies in non-small cell lung cancer in the early stage setting.
Hi, thanks for the introduction, and I'm glad to be here today speaking about, I think, an exciting new topic in resectable lung cancer. I'm going to share my screen here with some slides. And it's occasionally been crashing, so if I disappear, I will be right back. So in one moment as it loads successfully. All right, and I hope I'm still on the webinar here. So I'll be speaking about a very new topic in lung cancer, which is perioperative chemoimmunotherapy. All right, I think I'm back. Maybe one of the hosts can confirm if I'm back on live.
Yes.
Through. Good. Apologies, everyone.
Slides. Thank you.
Good. Be speaking about a very new and exciting topic, which is the integration of immunotherapy into our management of resectable lung cancer. And I'll first tell you why at least oncologists have been very excited about this development. Historically, and until very, very recently, we thought about lung cancer that could be removed surgically. The really standard thing was we did surgery up front, and then we followed it up with a course of we called postoperative or adjuvant chemotherapy. And this does improve outcomes and it reduces risk of disease relapse, improves what we call chance of survival at 5 years by about 5%. So people are benefiting from this, but not as much as any of us would like. And we know that for even resectable lung cancer, there's still very much a real risk of tumor relapse. Looking at 2/3 of patients by 5 years, and 1/3 of patients by 5 years for stage 2 cancer, and 2/3 or more with stage 3 cancer by 5 years. So there's risk here that we want to try to reduce for our patients. And preoperative therapy has become one tool to try to achieve that reduced risk of tumor recurrence. And what are some of the goals of using additional therapies in the preoperative setting? So you can hope of taking maybe a tumor that's a little too big to remove safely, try to shrink it and convert unresectable to resectable disease, so make surgery possible. You can try to reduce the extent of surgery needed, maybe reduce from needing a whole lung removal to just one lobe of the lung, so you preserve more healthy lung and reduce the potential extent of recovery needed from surgery. You can increase the chance of trying to get a complete resection, which means there's no residual cancer, either to the surgeon's eye or under the microscope in pathology. You can get information from that sample once you take it out, once you remove the lung after treatment. You can look at those tumor cells and say, how well did my preoperative treatment really work? How many cells appear to have died? And we hope by doing all this, you could improve survival, reduce risk of relapse, or change how the cancer and the body are interacting to modify that cancer biology. There are several tools we have available that have all been studied initially in the metastatic setting and are moving up into that surgically resectable lung cancer. So chemotherapy is familiar probably to many of us here. Those are infusional therapies usually for lung cancer. Historically, we've given them after surgery, but certainly they can also be given pre-surgery, trying to reduce that risk of relapse. Like I said, maybe about a 5% benefit there to doing that. We also now have the world of targeted therapy for lung cancer. These are usually oral drugs or pill-based therapies, but they're really targeted to very specific gene mutations in cancer cells. I'm not going to talk a lot about targeted therapy in the surgical management of lung cancer today, except to point out that there are a lot of clinical trials ongoing right now, looking at using targeted therapies before or after surgery for all these different gene mutations I listed there. and some which are approved, for example, for EGFR. But the therapy we're going to focus on today is really adding immunotherapy into this treatment strategy. Of course, these are infusional therapies. They've been approved in the metastatic setting now for many years in lung cancer, and they help the immune system learn to kill cancer cells most effectively. These are right now in lung cancer, usually what we call PD-L1 or PD-1 inhibitors. You can see in that little diagram there, the signal between PD-L1 and PD-1 sends a shutoff signal to immune cells, preventing them from killing the cancer cells. By blocking that signal, you can help the immune system activate and kill the cancer cells on your behalf. So that's how these therapies work. And that's why this PD-L1 level on the tumor cells, because it's the target of the therapy, can be important in understanding probability of the treatments working. So in the metastatic setting, we've known now for some time that adding immunotherapy to chemotherapy, giving them in combination, is more effective than chemotherapy alone. This is from one of the big original studies called the Keynote 189 study that looked just at doing this. They randomized people to chemoimmunotherapy or chemotherapy, and they showed that by adding immunotherapy, on average, people were living longer and having a better chance of tumor response, tumor shrinkage on therapy. So average survival time improved by almost a year, and the fraction of people living at 2 years almost doubled. And now you can see that on the survival curves there to the left. And our audience may have a mixed group here today. I don't know how much experience you might have looking at survival curves, but it's something that is often used in oncology presentations and papers to try to explain how well a treatment is working. I'm going to run through an orientation on that here for you today. Use the example here, relapse-free survival after surgery for lung cancer. You can look on the y-axis there, the percentage of people who are currently living without a cancer relapse after their surgery. The bottom is over time. And you can see if over time the number of people who are free from cancer drop off, you show that's kind of a worse outcome. You're seeing most people are having a cancer recurrence in this example. And then as the curve moves upward, you could get to a perfect outcome, which is a straight line across the top, which means all patients are remaining cancer-free for the entire study period. Now, usually our studies look more like that yellow line where we're trying to shift that line upwards. You can see that's what happened here in the Keynote study, where the blue line, which is the immunotherapy arm, did better than the red line, which is the arm that was chemotherapy only. So what do we have recently in this space in terms of actual approved drugs that are available in the clinic? So we still have the backbone of surgery plus post-surgery chemotherapy. We had an approval a couple years ago for people who are EGFR positive, adding 3 years EGFR targeted therapy, and that improved time before cancer relapse. And then we have also for PD-L1 positive patients, that immune target, we have approvals for 1 year of adjuvant immunotherapy, the atezolizumab, which also improved the time before cancer relapse on average. We're talking today more about preoperative treatment, and this is the newest data we have, which is neoadjuvant chemotherapy plus immunotherapy. And this is the Checkmate 816 study data. So I'm actually going to take us through that data in some detail, and I'll show you the study design and some of the outcomes we're looking at, trying to show benefit to this sort of strategy. So what was this study? This was a randomized study for people with a new diagnosis of lung cancer that a surgeon felt was resectable. There's some official stage numbers there, stage 1B to 3A. Those refer to tumor size and the extent of lymph node involvement. People had to be healthy. And then they were randomized to get either just standard chemotherapy, which was 3 doses, 3 weeks apart, pre-surgery, or same regimen, standard chemotherapy plus an immunotherapy drug called nivolumab. And then those patients went to surgery and then could be treated after surgery, however their treating doctor felt was appropriate. They looked at what's called a primary endpoint, which is the primary measure of whether the treatment was working in the study design. In this case, it was the pathologic response rate, so the chance of not having living tumor on a microscope slide, and event-free survival, so risk time until tumor actually came back. They also looked at overall survival, of course, which is we consider to be our gold standard endpoint in any trial. Do people actually live longer overall, regardless of their cancer status? So these are some of the measures we look at. How do you measure success of preoperative treatment? These apply to most clinical trials in cancer as well. You often see the response rate reported, the ORR, and that's what fraction of tumors actually shrink on their imaging scans. You can look at the pathologic response rate, That's looking at, if you actually take that surgical sample when it's removed from the body, what fraction of tumors, pathologic complete response rate is what fraction of tumors had no living tumor cells left behind. You can look at event-free survival, so that's how many people are living on average without tumor recurrence. And you can look at overall survival, which again is our gold standard. Our most strict endpoint for any study is, are you seeing improved overall survival? We consider that many times the very best endpoint that we're looking for. So in Checkmate 816, here's those survival curves for, this is event-free survival. So how long are people living on average without cancer relapse, or people who aren't having cancer relapse? And you can see it was improved by adding immunotherapy pre-surgery. And it went up from 20 months to 31 months, so almost a year by doing that. So it showed better survival post-op for these patients. You can also look, everyone worries with a neoadjuvant treatment or preoperative treatment, you don't want patients not going on to surgery because of something related to the treatment. So studies will usually report how many people actually got the planned surgery, were there any delays, any issues with the surgery. So here you can say that patients who got the chemo plus immunotherapy were actually more likely to go on to surgery. 83% went on to surgery versus only 75% who got chemo alone. So it seemed on average, it was actually making you more likely to get to your surgical resection. You can also look at what did that surgery look like? And you can see here that by getting the immunotherapy with chemo, you were more likely to be able to have a minimally invasive surgery, as opposed to say more open surgery, which is tougher to recover from. And you were less likely to need to have a pneumonectomy, which is a full lung resection, again, a bigger surgery with more potential long-term effects on health and well-being. You can then look, what about that surgical sample? Was the tumor actually dying in the samples? That's that pathologic complete response rate. So what fraction no living tumor cells visible? And that was a big improvement in orange there, adding immunotherapy. 24% of people, their tumor had no visible living cells versus only 2% if you got chemo alone. So more than a 10-fold improvement in the chance of seeing no living cells. We know also that it probably is a good thing, that if you have a pathologic complete response, that's that top curve, you were more likely to be cancer-free at 2 years, 93%, than if you did not have a complete response, where only 58% of people were cancer-free at 2 years. So likely for future study design, if we're able to look at things like pathologic response rates, we can almost predict from that surgical sample how happy we are with that treatment. That may allow for future study designs that allow us to modify treatment based on how good of a response we've seen to that initial preoperative therapy. So who might benefit the most from this treatment strategy? This is called a subgroup analysis, and you'll see this figure in paper. So what this shows is the dotted line is equal benefit either way. And then if your dots are falling to that left side of the line, it means that you were benefiting more from getting immunotherapy. If you're falling to the right side of the line, it means you're benefiting more from getting chemotherapy alone. I'll highlight a few things here. One, people with more advanced disease, that's that top line there, the top arrow. Through stage 3 disease, there was more benefit to adding immunotherapy. It was a little more equivocal. You're closer to hitting that dotted line there if you had earlier stage disease, like stage 1 or stage 2. And that second arrow, you also had the most benefit if you had a high PD-L1 expression on your tumor cells. And that's that biomarker that the drug targets. So when it's high, we know immunotherapy tends to be more likely to work. And we see that in this study as well. Now, it didn't mean that you couldn't benefit if your PD-L1 was lower, but the benefit was greatest if it was high. So right now, the FDA approval and the way it can be used in clinic is anyone stage 1B and higher with any PD-L1 score. But when your doctor's deciding if they might recommend it, they might be thinking, well, where do you fall on these sort of spectrums in terms of the extent of your disease, your PD-L1 numbers, your other health conditions that might impact risk of immunotherapy. And that may help them make a more personalized recommendation. So speaking of risk, so these are side effects in the Checkmate 816 study. So these are the most common side effects seen in at least 15% of people. And these are really standard chemotherapy side effects, what we see on chemo. Risk of nausea, other GI side effects like low appetite, low blood counts, things like that. These are often manageable medications, but they're things we watch for, and they do happen in both arms. Maybe more importantly, when you add immunotherapy, you think about some of these immunotherapy-related side effects. These are related to immune system activation causing autoimmune disease instead of just the anti-cancer effect that we want. The most common of these are things like rash or some hormone abnormalities, but there are a few that are kind of important when you're thinking pre-surgery, particularly the one boxed there, which is risk of pneumonitis. So, and that can cause lung inflammation, which can interfere with safety of surgery. So this is something that's tracked closely. These were all consistent with what we usually see in patients getting immunotherapy. There wasn't any extra risk seen. And certainly, as I said before, as we showed before, patients went on to surgery still at actually a higher rate despite this treatment. So it seemed to be offering benefit, and these side effects, while present, were not preventing patients from, on average, getting the treatment that they aim to do with surgery. But depending on your health, for example, if you have autoimmune disease or other medical conditions, these risks might be different. So it's something your doctor would also consider when giving advice about using this regimen preoperatively. So I highlighted Checkmate 816. That's the top line here. This is an example of a lot of other perioperative immunotherapy regimens that are either in clinical trials right now or have some published data. And the blue boxes are immunotherapy components. The orange boxes are chemotherapy components. You can see surgery there in the middle. So pre-op therapy is on the left, post-op therapy is on the right. And these vary in whether they do all pre-op therapy, all post-op therapy, or a combination of both. And they vary in whether chemo is required or where it's used. So we're still waiting to understand, is all pre-op going to be better? Is all post-op going to be better? Is it better to do both? And that's something we're all going to be watching very closely as we get more and more data from these different clinical trial strategies. So what about driver mutation positive lung cancer? You might have a driver mutation or know someone who has a driver mutation. This is a very different subset of lung cancer. These are things like EGFR positive, ALK positive, ROS1 positive lung cancer. These often strike different patient populations than average lung cancer. Patients are more likely to be younger, more likely not to have a significant history of tobacco use, for example. And these tumors interact differently with the immune system. Now, in the metastatic setting, so more advanced disease, we know that having these sorts of mutations really seems to reduce the chance of tumor response to immunotherapy alone for lung cancer. That's what this graph here shows. It's from what we call retrospective data. So they looked at all their patients that were treated and looked back at how people did. And they showed that for people who had some of these classic sort of less associated with tobacco use mutations, highlighted the orange bar there, they were most likely to have disease progression as their best response to treatment. So really no response at all, and that's the dark blue lines. And because of this and other similar data, a number of these different clinical trials looking at using immunotherapy don't allow people who have some of the most common mutations like EGFR and ALK from participation because they're worried that treatment won't be effective. In my own practice, I'll usually avoid these sort of treatments for some of these classic mutations like EGFR and ALK, and instead really focus on getting these patients access to EGFR, ALK target, or other targeted agents and other types of clinical trials. So I think it has two different tracks. You're either on the immunotherapy track or you're on the targeted therapy track. So remains to see, what are some of the unanswered questions here? And some of these that come to mind for me are, is immunotherapy best given before surgery, after surgery, or at both phases of treatment? We have trials exploring all of these different options. Should patients with low PD-L1 levels or earlier stage disease, like stage 1 or stage 2 disease, still be treated with this regimen? They didn't benefit as much when you look at those little subgroups, but still have potential for benefit. What if you get your cancer out and it looks like there wasn't a really strong anti-cancer effect? There's still a large fraction of the tumor that appears to be alive after your preoperative treatment. How best do we change that risk? Is there anything that can be done to maybe treat postoperatively to try to reduce people's risk of relapse in the future? And lastly, of course, how do you best manage cancers with all these other driver mutations, especially like ROS1, RET, HER2, which are a little less common and we have less data? Should these patients get this sort of regimen? Should they get targeted therapy regimens? And how do we decide? And so my takeaway points here, this is again, brand new really in the last 6 months for people with lung cancer, that the use of preoperative chemoimmunotherapy reduces the risk of cancer relapse after surgery for lung cancer. And that benefit is greatest if you've got stage 3 disease or high levels of PD-L1 expression on the tumor. And with that, I think we're going to go to our Q&A or panel discussion. Thanks.
Great, thank you. Thank you for that wonderful talk. I'd like to start our panel discussion with Q&A. If it's all right with you, Puneeth and Julia, we'll go by first names. Please call me Tiziana. And, just to kind of remind everybody, we're really having this event for patients with lung cancer, their caregivers, for survivors. So keeping in mind the patient perspective in some of our discussion, I think one thing that I wanted to ask you, Julia, to start out with was, you brought up a very important topic of biomarker testing in early stage lung cancer, given that for some patients, perhaps the strategy would be different. Could you outline from a patient perspective, what should they be talking to their doctor about if they have a diagnosis of early stage lung cancer and they're trying to decide, do they think that preoperative strategy with chemoimmunotherapy is a good option for them?
It's a great question. And it's actually a really important question to ask your doctors, because it can get them thinking about it and make sure you get the right testing. And the short version is, for people who have a lung cancer that's thought to be removable by surgery, about half of lung cancer will need, we call mutation testing, particularly for that EGFR mutation I mentioned. That one's the most common of the mutations we find in lung cancer, particularly for people with less history of smoking, but can happen to anyone. They really need very different treatment with these EGFR targeted therapies. So really that's the critical one right now. I will say, if you're able to get it, we always like to get our mutation testing as part of what we call broad next generation sequencing, which tests not just for EGFR, but for several hundred different cancer related genes. Many of these, we don't know what to do with them yet, I will admit, but there's a subset of them that might change how your doctor thinks about your upfront treatment. That's not required by official standard of care right now, the broader testing, but I think we're moving that direction. If it's available, it's nice to have. The other biomarker that's not officially required just yet when thinking about preoperative treatment, but I think is really helpful, is that PD-L1 level. That's a test that's done on your tumor biopsy. Again, if it's high, predicts for a better response to immunotherapy. And if it's really high, your doctor really should be, I think, thinking very carefully about trying to get immunotherapy into your regimen if it seems reasonable. So not required, but can help you have a more nuanced discussion. And definitely it's required if you're going to get this post-op. So you might be in a situation where you've already had your surgery, maybe you're recovering from surgery, and you're going to see your doctor and talk about post-operative therapy. Even if you didn't get this immunotherapy upfront preoperatively, you can get it post-op. There's that 1-year regimen available if you're PD-L1 positive. So it's still useful to have that biomarker so you'll know all your treatment options.
Great, thank you. So this one goes for Puneeth. I'll read the question to you. We've got some great questions for.
Are they from the chat?
Yeah.
Oh, sweet.
The
Okay.
Q&A.
Yeah. I can read it, and I'll try to answer the ones relevant to me, if that's okay.
Sure. Why don't we go with the first one?
Yeah, the first one is a great question. What do you see as more important in the biology of oligometastatic disease and likely long-term outcome? The de novo biology of oligometastatic disease, meaning at the diagnosis point, or a great induced oligometastatic disease state after a robust response to systemic therapy in a patient who didn't start with just a few metastatic sites? I think there was one other person who had an interest in that question. I think it's an outstanding question. I think personally, without enough biologic insight, I would say that I would personally rather have a patient of mine have oligometastatic disease from diagnosis and who sustained that oligometastatic disease state through the course of several months of time before we would consider local consolidation. The reason for that is that I almost look at our small cell experiences. Small cell lung cancer is certainly a different cancer, but those patients often respond very rapidly to chemotherapy and radiation therapy. And I think the same reasons biologically that they respond rapidly to chemoradiation are the same reasons they recur. And so they have a different kind of biology. And so I would want to see someone demonstrate stable oligometastatic disease over the course of months, if not longer. And I would have probably a stronger hope that using local therapy in those patients where they haven't figured, their disease hasn't figured out how to met out to more sites is probably a better chance at a better at a better outcome. Julia, did you want to say anything about that, or did you?
Yeah, I agree. I think I find it Again, I think we need more data. In my own practice, I'm much more comfortable thinking about aggressive consolidation therapy for someone who truly appears to have very limited initial upfront disease. And then I hope that there is that chance, maybe we're lucky and those are the only sites of disease and we can go after them aggressively. And I'll discuss that with my patients. For those who've had more extensive disease, but have a good response to treatment, like a response to targeted therapy, I'm less likely to do consolidation treatment right now because I don't know which lesions are going to be the ones that are the problem lesion in the future where I'm going to want to treat it. So I'm less aggressive in that setting and will usually focus on continuing the systemic therapy. But I agree, it's an evolving area, and I don't think we know for sure which is the best option right now.
And I think, that's why I think a lot of people will wait for oligoprogressive states, that if there's oligoprogressive disease, that they must have been on systemic therapy for quite a bit of time, and they only still have a few limited sites that are evolving, and maybe the local therapy will help with those with those evolving sites and allow the patients to stay on the same systemic therapy that's working in 90% of sites or something. That leads to the second question. These trials of local consolidation are generally slow to enroll, unfortunately, even with broad enrollment. That is correct. Is it feasible to run trials that limit just patient enrollment with driver mutations? I think the answer is yes to that. Are they only going to be done in Asia and then viewed skeptically as not generalizable outside of Asia? I think we still have a large patient population with these mutations on the coasts, at the very least in the United States. There was a trial with EGFR with EGFR mutant disease where patients were treated up front with local therapy. The SINDOS trial, it was a phase 3 randomized trial, amazing outcome, improved overall survival. There was some weird findings at 6 months that didn't make a lot of sense on that trial with respect to the progression-free survival and OS differences and treatment response differences between the two cohorts. Yes, I mean, I think at the end of the day, it's nice to see multiple studies demonstrate a similar outcome before it's completely made a standard of care. This is not like a drug that goes to an FDA for approval. This is more a change in treatment paradigm. And I think having multiple studies that show the same results will probably be more necessary to convince a greater number of physicians and patients that it's the appropriate therapy.
But I think that brings up a very important point about the importance of clinical trials from a field perspective, from the patient perspective, from the clinician perspective, that we can design clinical trials that are going to be applicable, that we create eligibility criteria that patients can get to, that we bring clinical trials closer to the patient and make it more widely available. And I just wanted to bring up another point about your talk. Puneeth, you said that perhaps in the oligometastatic disease, some of the criteria may not be optimal. And you talked a little bit about thinking about quality of life as an important measure in trials that are not always captured. And I had a question for you about that in an oligometastatic disease trial where you're adding radiation, in terms of the timing of measuring the quality of life, endpoints may alter that endpoint as well. So what are your thoughts on how would we do that?
Yeah, I mean, that's absolutely right. When we give radiation to the chest or to an extra thoracic site, you're absolutely right. You can see toxicity at very different time points. So we worked very closely with Ben Mofsis at NRG, who's really a quality of life expert and happens to be also a thoracic radiation oncologist. And we're really trying to capture quality of life metrics at the time of the registration on these trials, but every 3 months for as long as those patients are on the study. So that means even after progression, which is our primary endpoint for the phase 2 portion. And the reason is for what you exactly said. There are some patients who will have early acute toxicity, which will affect their quality of life. There are also patients who will have chronic delayed toxicity. And so it's really critical that we don't just simply say, oh yeah, the primary endpoint has been met, stop doing QOL measures. We're going to keep doing that until probably death on the study. And so that will help us understand whether things, the toxicity and the quality of life changes are delayed or they're acute, and really go towards what you're getting at, which is timing of events and outcomes.
We'll have time for 2 more questions. I wanted to blend 2 questions in for Julia. One is, while we wait for more data, what do we actually do with post-op patients when patients have a bit of tumor shrinkage, but mostly residual viable disease after chemoimmunotherapy? Would it be more of the same treatment if that didn't work that well before surgery? And adding on to that, it's the pre-op versus post-op. If we can't deliver post-op therapy in, numbers that we hope to, is it better to do it pre-op because we'll have better delivery?
Yeah, those are two great questions. I think ones that we all think about as well. Pre-op versus post-op, it's been repeatedly shown in clinical trials and other data sets that we are more likely to successfully give the full course of therapy if it's given pre-op, and means that we're more likely to get patients all those doses of chemo and immunotherapy we planned for. With post-op treatments, people have just gone through a big surgery. You're trying to recover, you're trying to return to your normal life, and it's hard to think about doing another 3 months worth of chemotherapy after you've recovered from your surgery. And sometimes people have complications from surgery that take longer to recover from than we want. And that can also delay or prevent you from getting things like chemotherapy or immunotherapy. So upfront, doing it up front seems to allow us to get it to people more effectively. That's one advantage of preoperative treatment. I think both an advantage and a challenge of preoperative treatment right now is that surgical sample. When you look at what fraction of tumor cells have died, and they'll usually give you a percent viable tumor left. Under 10% is good, 0% is best. But most people will have, so 2/3 of people will still have some, 3/4 of people will still have some viable tumor remaining. And right now, we don't have a great tool available to change that outcome. I want to see clinical trials, maybe we can add something new. Any treatment we add, of course, adds risk of toxicity. So in my own practice, I'm not adding additional treatment, but I am watching closely, and hope to have additional options in the future. I'd like to highlight, even if your tumor shows a lot of residual tumor left, you've still had, in most cases, you've still had a complete surgical resection. You still can be cured by the intervention you've already had. It's just we're going to be watching closely.
Great. We've got some additional questions, and I think this one can be for both of you. One is, does the cytomide disease matter in terms of long-term success? And the second one would be, do locations of initial stage 4 progression that were never in the brain help predict future treatments in any manner?
I mean, I personally think that, visceral mets, meaning to the liver and to other sites, are probably portend a worse prognosis. I know patients with bone-only metastases who've led an incredibly long life after diagnosis. And so I think at the end of the day, as we collect more real-world data as well as data on study, we'll be able to really get to the heart of the matter about those different possibilities. But I think, as I said, the visceral, meaning the internal organ mets, are a little bit more dangerous in terms of outcomes. Yeah,
and this comes to mind when I'm thinking about how aggressive to be about consolidative therapy or treatment for a limited metastatic disease. Two sites that I feel most optimistic about when I'm doing this are actually the adrenal glands, which lung cancer often will spread to as an isolated site. So I'll be very aggressive managing those if you have one adrenal metastasis. The other site, which is counterintuitive, is actually to the brain. If you have just one site of CNS spread, sometimes that really is the only site of spread. That's another type of disease where we'll often be quite aggressive treating your lung disease as if it were just lung disease, maybe with chemoradiation or surgery, and also treating that one spot of brain disease with radiation. And patients hear brain metastasis, and of course, they worry because it sounds like a bad area of spread, but actually it can be some of the best outcomes in terms of limited spread.
Yeah, that's great points. When I remember reviewing the Keynote-24 data with the long-term survivors in the immunotherapy trials with PD-L1 high expression, there weren't really any clinical factors that really predicted people who were going to be the long-term survivors. So I definitely think that additional research is needed to really define the answer to that question in terms of, the long-term survivor and long-term success. I think that's a great question. And certainly we're seeing, better therapies, both in radiation as well as immunotherapy and targeted therapies. So a lot of room for optimism. Just wanted to close out our panel discussion and move on and hand it over to Dr. Patel for our next session. Thank you so much to Julia and also Puneeth for joining us today, and for everyone joining and asking questions. Please stay on with us for our next session.
Thank you.
Thank you so much, Doctors Leal, Iyengar, and Rota. That was a great morning session, and hope to continue it with really our excellent panel of afternoon speakers who I'm so excited to intro. I actually tried introing earlier. But to start with, I now want to introduce Dr. Akash Desai, MD, MPH. He's an assistant professor at Mayo Clinic in Rochester. He's actually a former patient education ambassador for GRACE, and so it's delighted to welcome him back as a member of the career development community for ISLAC. And he's a recipient of the ISLAC Early Career Award and Conquer Cancer Foundation ASCO YIA Award in 2021. And so I'm delighted to introduce him as he's going to talk to us about therapeutic options in driver mutation metastatic non-small cell lung cancer refractory to frontline small molecule inhibition as we start off our next segment in advanced non-small cell lung cancer. Thank you, Dr. Desai.
Thank you so much for that warm introduction, Dr. Patel. Are you guys able to see my slides?
We can now, yes.
Okay, perfect. Well, thank you very much for this opportunity. So as introduced, I'm Akash Desai from Mayo Clinic, and I'm going to be talking about therapeutic options in driver mutation positive metastatic non-small cell lung cancer, which is refractory to frontline small molecular inhibition. These are my disclosures. And so really, I'm going to break my talk into 4 different parts. Initially, we're going to talk about the metastatic non-small cell lung cancer and in terms of what kind of oncogene drivers are present, in this subset of metastatic non-small cell lung cancer. We'll talk about resistance mechanisms and then subsequently talk about the general and some specific strategies to overcome resistance in this area. So when we talk about stage 4 non-small cell lung cancer, the treatment landscape in 2022 is quite complex and is largely driven by 2 different factors. One, whether there is any presence of actionable mutation that is detected on the tumor. This is a list of ever-expanding mutations, thankfully. But currently, there are about 10 different mutations that we would want to test for. At least most of us send next-generation sequencing, which will cover most of these alterations. But for the patients where the tumors, we are not able to identify any actionable mutations, then immunotherapy forms an important backbone of treatment. And I think Dr. Kim will be discussing that in the later talk. My focus really is going to be in this subset, in this category of oncogenically driven metastatic non-small cell lung cancer. And when we talk about oncogene drivers, we've identified numerous different drivers for each, different tumor types within the metastatic non-small cell lung cancer. This plot here just kind of shows the prevalence and percentage of different oncogenic drivers. As you see, about 30% of the tumors are driven by KRAS, another 30% by EGFR, and then the rest, have a smattering of different fusions like ALK, ROS1, RET, and also ERBB2 mutations, some splicing mutations in MET pathway and others. And so within these 10 different actionable mutations that we know as of today, there are various approvals, and this kind of snippet just kind of tells us about the different drugs that are currently FDA approved and some of the data that has led to the FDA approval. I want to point out your attention to the ones that are mentioned with an asterisk, which are actually the NCCN preferred regimens in the current version of the NCCN guidelines. And I think it's important to realize that some of these approvals are actually in the second line for some of those newer upcoming oncogene drivers that have been recently targeted, like EGFR exon 20, KRAS G12C, and HER2. But a lot of the others, which we know quite along, especially for EGFR and ALK, which have been targeted, almost a decade now, most of these targeted mutation therapies are actually used in the first line, specifically osimertinib for EGFR. There's alectinib, brigatinib, and lorlatinib for ALK. There are a couple, for MET exon 14, NTRK, RET, as well as the ROS1 and BRAF V600E. When we talk about frontline therapies, this vignette here just demonstrates, different the duration of progression-free survival, meaning that when the time between the initiation of treatment to progression of the cancer for all these different targeted therapies across these different mutation spectrums that I just showed you. And I think what kind of appears and stands out from this figure is that you would say that median progression-free survival is ranging from about 12 months to 36 months, 1 to 3 years. And that obviously depends on the molecular target. However, most patients will experience tumor progression with long-term follow-up. And most of this progression is mediated by resistance to the frontline therapies that we administer currently, be it osimertinib or alectinib, brigatinib, and subsequently others for other mutational subtypes. And so talking about resistant mechanisms, it is, I think, very important to understand when we see progression of the cancer after a frontline therapy, what is the mediated resistance mechanism? And there are, quite a variety of resistant mechanisms that have been identified till date. And this is just kind of some of the major classes or categories of resistant mechanisms that we see today. So it could be mutations in the target of the drug or the tyrosine kinase inhibitor that the patient is currently on. There could be switching of different bypass signaling pathways, so meaning other pathways from their mutationally driven tumor that are activated and subsequently lead to resistance and progression of the cancer, including oncogene amplification or oncogene rearrangements. The other mechanism could be the mutation in downstream effectors. So not just if we are targeting this particular tyrosine kinase domain, there could perhaps be mutations in the downstream pathway effectors, which could lead to progression of the cancer. And then another subtype of mechanism of resistance that we've identified is histologic transformation to a different histology from a non-small cell lung cancer, be it a small cell lung cancer or a non-squamous type of lung cancer being converted to a squamous a subtype. And so this histologic transformation is also another mechanism of resistance that has been identified. And so now I'm going to talk about and focus first on the general strategies on how do we overcome resistance in certain pathways. My talk will mostly be focused on EGFR and ALK because that's where we have the majority of the data currently, but I will also try to cover some of the other mutations, the rarer mutations in the last few slides. So the snippet here usually, really illustrates, I think, the point that we were also trying to make in the morning session. So when we have a patient, especially when I'm thinking about the subtype of oncogene-driven metastatic non-small cell lung cancer who is responding to the first-line treatment, I think the progression can be classified into 3 different types. Essentially, there is one being systemic progression. So there's a multi-site progression involving either previously responsive sites and perhaps some new additional sites of tumor. There is oligoprogression, which I think Dr. Anger covered, elegantly in the morning session, talking about the differences also. I mean, the definition currently is not a standard definition, but for the purpose of this talk, I'll kind of, think about limited sites, maybe 3 to 4 amenable to local therapy. And then there's also a CNS-only oligoprogression, which I think we touched upon in the Q&A session. However, I will mention that with the frontline therapies now being mostly next generation tyrosine kinase inhibitors, I think thankfully we are seeing less of CNS-only progression, especially in the oncogenic driven subsets. However, I think oligoprogression and systemic progression still remain very relevant and difficult issues to treat. So focusing first on oligoprogression, I think we heard that perhaps radiation as a local therapy, as well as maybe surgery, may be helpful and enable us to continue the tyrosine kinase inhibitors, the frontline therapies that we have patients on while trying to eradicate some of these oligometastatic sites. Now, there is some data that is emerging specifically for oncogenic-driven non-small cell lung cancer using local therapy. There is this retrospective case series about 38 patients with ALK and ROS positive metastatic non-small cell lung cancer who were continued on crizotinib beyond radiologic progression. And it was shown that patients who did receive any sort of local therapy, mostly radiation in this case, did have a prolonged PFS2, which is defined as time from initial imaging evidence of progressive disease to terminating the usage of their frontline therapy. So essentially trying to increase the mileage you can gain from the frontline therapy by using local therapy for oligometastatic disease. More recently, the CURB trial was presented. So this trial essentially included patients both with metastatic non-small cell lung cancer and breast cancer. And then they were subsequently randomized to receiving standard of care without any radiation and standard of care therapy with radiation to all progressive sites. And here, just focusing on the subset of patients with lung cancer, there was the benefit of radiation with increasing the median progression-free survival, which I would think about as a progression of the cancer while being on the treatment compared to not receiving radiation. So patients who did receive radiation had a longer progression-free survival and enjoyed longer time free of progression, essentially, from the cancer compared to 9 weeks without radiation therapy. One caveat, though, is this trial particularly had about 86% of the patients did not have any driver mutations. So only 14% of the patients are kind of, that's the relevance for particularly in the oncogene driver subset. But I think there is emerging data, and I think currently in clinical practice, I think I've seen many physicians use that strategy where they're trying to locally target the oligoprogressive sites while trying to still continue the frontline therapy, especially if the patients have had good response. The tumors have had good response for this particular oncogene driver tumors. So when we talk about mechanisms and how to overcome, systemic progression, I think it becomes very important to molecularly analyze either through ctDNA or tissue specimen from the primary tumor that what kind of resistant mechanisms are we dealing with. If there is a targetable resistant mutation, then perhaps we should target that. And if, either through ctDNA or tissue rebiopsy, we identify something that is unknown or where we do not currently have targeted treatment, then potentially offer other benefits other therapies that may benefit for those markers or best supportive care. And so really, I'm kind of thinking of this as, precision oncology 2.0 there, where initially in our first line treatments, we're already doing, matching the treatments to the mutations that we find in the tumor. So perhaps even in the second line, we need to do that when we see progression of these tumors, we need to identify the resistant mechanisms and again, kind of tailor treatments based on that. And so, there are various types of approaches that we are taking currently. So just kind of going by the different categories that we know of today. So for particularly when we see mutations in the drug target, I think certain mechanisms and strategies are to either administer next generation TKIs or PROTACs, which are proteolysis targeting antigen chimeras. Essentially, these are molecules which bind to the target oncogene driver and on the other end bind to the proteasome and cause proteasomal degradation of these oncogenic driven tumors. Then I talked about bypass signaling as one of the resistance mechanisms, and really we can target this by either combination of different tyrosine kinase inhibitors, depending on what pathway is activated, or antibody drug conjugates. And I'm going to talk a little bit about some of these strategies. When we talk about mutations in downstream effectors, we perhaps need selective inhibitors of these downstream effectors, as well as combination TKIs. And then for histologic transformation, our current strategies include using chemotherapy or immunotherapy for targeting small cell and squamous cell lung cancer. So like I mentioned, I'll first focus more on EGFR and ALK, and then we'll talk a little bit about other resistant mechanisms for other subtypes. So talking about EGFR, I think really is the poster child in terms of us understanding the mechanisms of resistance. So as you see here, this is a very elegant study by Dr. Leonardi and colleagues, where they actually looked at mechanisms of resistance to osimertinib. And as you see, there is a variety of different mechanisms of resistance, one of them being actual mutations at the drug binding site, like C797 mutation can lead to impairment of binding of osimertinib and thus confers resistance to osimertinib as a resistance mutation here. The other particular mechanisms are MET amplification. So this is like the bypass signaling category of mechanism of resistance that I mentioned earlier, which occurs in about 7 to 15% of patients with EGFR resistance to osimertinib. And then, it's important to note that, for about half of these particular resistance, we don't really know what the resistance mechanism is for the tumor. And so there's obviously a lot more work needs to be done in this space. There is actually work being done in identifying trends and potential categories that we should be looking out for. So this, this study presented by Dr. Ramalingam at the recently concluded World Lung Meeting actually took about 1,300 patients who had experienced progression on first-line osimertinib, and through really elegant, liquid biopsy studies demonstrated that perhaps if the progression is occurring within the first year, perhaps bypass signaling pathways like MET amplification may be more important and more prevalent. And if the progression occurs, post a year, then perhaps, on-target resistance mechanisms such as the EGFR C797 may be more prevalent in these cases. So, this is kind of trying to identify some trends so that we can tailor our treatments accordingly. So when we talk about acquired resistance to osimertinib, again, kind of thinking through those categories. So if we have on-target resistance, I'm going to be talking about, different strategies, including fourth generation EGFR TKIs, clinical trials, and perhaps, going back to first and second generation EGFR TKIs in some cases. Talking about the bypass resistance with MET, there is actually a variety of strategies that are currently ongoing, which include different antibody drug conjugates and different combinations with TKIs, which I will be covering in later slides. And then for histologic transformation, again, chemotherapy with or without immunotherapy, and also continuing perhaps the TKI if there was good response, previously. And then for really the mechanisms where the unknown mechanism of resistance, we have different antibody drug conjugates, as well as chemotherapy, immunotherapy, and perhaps anti-VEGF combination that I will also discuss as another potential strategy for overcoming resistance to osimertinib. So first, focusing on the on-target resistance. So this figure really demonstrates the IC50, which is the inhibitory concentration where 50% of the cells, the tumor cells, are killed in vivo studies. And what we see with the red is where we need a lot of drug to kill the tumor, compared to the green where we need a little bit less of the drug, which perhaps means that these mutations are sensitive to these drugs in green more than the ones in red. And so what we see here, that when we talk about the C797S mutations and maybe compound mutations with T790M and C797S, that osimertinib doesn't really do a good job of killing the tumor cells. But when we compare it to the next generation, fourth generation TKIs, we see some greens here, essentially showing that these drugs, these mutations are sensitive to these drugs, and so this is potentially a strategy. You do see here that some of these studies have shown that gefetinib may be able to act on these mutations like C797S. However, if there is a T790M co-mutation present really here, then it wouldn't be an effective strategy. So there are a variety of these strategies, especially with the fourth generation EGFR inhibitors that are upcoming and currently in clinical trials. We could also look at TKIs plus EGFR targeting antibodies. There have been studies done in the first line, which have shown some benefit. Perhaps this could be another strategy specifically for on-target resistance, and then the novel antibody-based approaches that I will be discussing in subsequent slides. Here is a list of the clinical trials specifically for these on-target resistance mechanisms and these fourth generation TKIs, which are currently under study, for different tumor mutations and co-mutations, but specifically for the C797 type of mutation, which are either preclinically being studied or in phase 1 and phase 2 trials. Now, when we talk about overcoming off-target resistance, specifically the bypass mechanism with MET that we talked about, there actually till date have been, these about 5 of these studies that have been reported out only in the last 1 or 2 years. And this, table really kind of summarizes the different treatment strategies. So osimertinib has been combined with savolitinib and tepotinib, which are MET TKIs. It has been combined with an MET antibody drug conjugate. So antibody drug conjugate really being an antibody which targets a surface protein, but then it is linked with a chemotherapy agent. So think of this as a smart chemotherapy where it can enter into the cell and release the chemotherapy so we can truly target the tumor cells. Then there are other strategies with lazertinib, which is also a third generation EGFR TKI similar to osimertinib, but then combining it with a sort of a bispecific antibody called amivantamab, which targets both EGFR as well as another MET target, so the EGFR MET bispecific antibody. And then there's also another strategy of combining these TKIs antibodies with chemotherapy. As you see there, these studies have different sort of biomarker selection criteria based on whether you identify MET amplification or expression, but really the overall response rates you see in terms of the shrinkage of the tumor is really kind of consistent, about 30 to 50%. So these are really emerging as useful strategies in this particular subset of tumors where we have MET amplification as a resistance mechanism. So this is the picture of antibody drug conjugate. Like I mentioned, it's an antibody which is kind of linked through a linker with a cytotoxic payload. And currently the two antibody drug conjugates, which are used as which are used as strategies, especially when we have unknown mechanisms of resistance, is targeting the antigens called TROP2 and HER3. These are two different antibody drug conjugates, datopotamab deruxtecan and patritumab deruxtecan, and they have been studied in patients harboring these in patients with tumors harboring these oncogene-driven tumors, and you see the overall response rates are in the range of about 30 to 40%. Another strategy, I think, which has emerged, especially since the Empower 150 data were presented, is the use of chemoimmunotherapy with atezolizumab and chemotherapy, but adding an anti-vascular endothelial growth factor agent called bevacizumab. There was another trial recently presented with sintilimab and a biosimilar of bevacizumab along with chemotherapy. It is important to note that these trials were designed for all patients with metastatic non-small cell lung cancer, but did have certain subsets where they included patients who had EGFR-driven metastatic non-small cell lung cancer. And they did end up showing some PFS and overall survival benefit here as well. Although there was slight increase in toxicity. So obviously these are another strategies, specifically when there are no clinical trials available, particularly in an institution. And I think these are valid strategies we need to be discussed with your physician. And there are, again, with this immunotherapy and chemotherapy and anti-VEGF combinations, there are multiple trials that are currently ongoing specifically for patients who experience resistance. One of them, Checkmate 722, was testing nivolumab and chemotherapy versus nivolumab and ipilimumab and chemotherapy. So dual immunotherapy was recently reported at the ESMO Asia conference to be negative. And so I think we are awaiting studies which are specifically including and incorporating the bevacizumab or anti-VEGF agents, because there seems to be some activity that is offered by these particular addition of these particular agents. And here I'm summarizing some of the strategies that I discussed, fourth generation TKIs, combinations with antibody drug conjugates here, as well as the bevacizumab-based regimens with chemotherapy and immunotherapy. All of these trials are currently ongoing. So I think really it's going to be an exciting time in terms of us figuring out to strategize and target these mechanisms of resistance. Moving over to ALK, again, similarly to EGFR, ALK also especially when we're talking about lorlatinib, there are other resistance mechanisms which happen on target, be it I117N or L1198F and others. So that is, again, the mechanism of on-target resistance. There are other mechanisms such as the activation of other bypass signaling pathways, and similar to what I just described earlier, squamous cell transformation as well as the small cell lung transformation. And again, the resistance, and I think you'll see a theme emerging here that for each of these molecular subtypes, where we are trying to target the resistance, I think the common theme is to figure out whether the resistance is on target or off target, and then based on that, you kind of strategize in terms of what to do next. And so for ALK, if there is an on-target resistance, again, there are fourth generation TKIs currently being studied in clinical trials. There is preclinical activity against those compound mutations that I just showed. Again, PROTACs, there are a variety of PROTACs being studied preclinically, and then using antibody drug conjugates and other combination targeted therapies and chemotherapy when we are talking about the transformation subsets. And so for the fourth generation ALK-TKIs that are currently in clinical trials, they are smaller, they are more compact, and so they have less of a steric hindrance. Essentially, they're easier to fit into the pocket where the mutations may actually cause the frontline therapies to have some difficulty to fit into those pockets. They're highly potent to both single and many lorlatinib-resistant complex mutations. There are currently two different fourth generation ALK-TKIs. There's TPX0131. These are some of the graphs showing preclinical activity, showing tumor shrinkage. And then there's also the NVL or nuvalent compound NVL655, which also is showing good activity in these compound mutations for lorlatinib-resistant ALK-driven metastatic non-small cell lung cancer. And here again, as we saw for the EGFR, there are a whole host of different trials ongoing, some for on-target resistance with fourth generation TKI, and others for trying to target the bypass mechanisms with other inhibitors. And then there are certain trials which are also incorporating the antibody drug conjugates that we talked about also into the second line. Just a couple of slides to talk about the less common. I guess KRAS is obviously more common. However, because we just had an approval a year or so ago, I think we're still trying to figure out the different mechanisms of resistance that we have. This is what we know so far in terms of acquired resistance. There is certain co-mutations for KRAS may confer innate resistance, but when we're talking about acquired resistance to frontline therapies, there is, again, you see that common theme emerging that maybe there are alterations in the target, there may be downstream activation of other pathways, there may be upregulation of the bypass signaling pathways, and transition to perhaps small cell type of lung cancer. And there are, again, variety of strategies that are currently ongoing, and some of them in clinical trials, targeting upstream, targeting the upstream SHP2 and SOS1 pathways, as well as targeting the downstream pathways with dual RAF and MEK inhibition, or MEK inhibitors that are currently available, such as trametinib. Talking about ROS1, I think one thing of importance to note, especially when ROS1, the crizotinib still has been, there are certain patients who have been on crizotinib, so I think CNS penetration here is inadequate, and so this may become an important mechanism of resistance, specifically talking about ROS1. But again, there are a variety of other mutations that can occur to other agents which do have good CNS activity, and again, there are, depending on what frontline strategy is, there are, again, off-target resistances and on-target resistances and other mechanisms. For example, this is a scan for a patient who was initially on crizotinib, subsequently developed a MET bypass-driven mechanism, and then was targeted with cabozantinib, and you do see the shrinkage in the lung mass there. So again, trying to identify the mechanism of resistance and targeting it has been beneficial, especially in the case reports that are coming out even for these rarer tumor subsets. For RET, again, there are quite a lot of unknown mechanisms of resistance, but again, you see the bypass mechanisms are quite prevalent, and then some of those may actually have on-target resistance to MET. This is demonstrating selpercatinib, the G810 mutation, which is again causing steric hindrance and does not allow selpercatinib to bind to the drugs to the site of action. And then these are the other bypass mechanisms such as RAS, MET, BRAF, and FGFR1, which have been identified in RET resistance. BRAF, sort of a similar story. I think BRAF particularly, currently we are only able to target V600E with the dabrafenib-trametinib combination. There are other agents in development, both for that as well as for overcoming bypass resistance, especially with the pan-RAF inhibitors. We can also inhibit the other RAFs except for the BRAF, and especially the downstream ERK pathways as well. So I just, kind of to end my talk, I'll say we talked a lot about overcoming resistance to frontline therapies. I think there are also emerging approaches to actually even prevent or maybe delay recurrence or resistance in these tumors. And I think we heard some of that again in the morning session with perhaps introduction of TKIs in the neoadjuvant setting. We heard about the adjuvant targeted therapy of osimertinib in EGFR, subset of resectable non-small cell lung cancer, perhaps utilizing TKI for consolidation therapy for, and perhaps when we do have better MRD assays, looking at TKI combinations there, and then also bringing potentially the rational combination therapies for first-line treatment of metastatic disease and incorporating ctDNA to guide the addition of a second drug. I think these are some of the emerging approaches. None of these are currently standard of care except for the osimertinib, but this is just some thoughts and where I think the field is heading in the future. So with that, I would like to end my talk and thank you so much. And this slide is just showing how far we've come in the last 15 to 20 years, where we were just treating everyone with carbotaxol, and now this, the increasingly complex algorithm of treatment for metastatic non-small cell lung cancer. Thank you so much.
Great talk, Dr. Sai. Thanks for starting our afternoon our second session on advanced non-small cell lung cancer. Next, it's my honor and privilege to be introducing Dr. Shoal Kim, MD, MPH. He's an assistant professor at Georgetown University and a specialist in thoracic oncology. He's was a clinical fellow in hematology and oncology at the NCI. And he received the Norman Rawls Young Investigator Award from the Conquer Cancer Foundation of ASCO in 2018. It's my privilege to be introducing Dr. Kim, who will be discussing treatment selection in non-driver mutation frontline non-small cell lung cancer, followed by a panel discussion for both of the session speakers.
Thank you very much, Dr. Patel. So thank you for the invitation to speak about the frontline treatment of advanced non-small cell lung cancer without actionable driver mutations. And so here in this presentation, I will go over key clinical trials of immunotherapy in advanced non-small cell lung cancer. And as alluded before, this is an ever-evolving landscape. And to summarize the results of the key clinical trials, I think it can be well summarized by this one picture where we show that the immunotherapy-based approach is superior to platinum-based doublet chemotherapy, be it immunotherapy by itself or in combination with chemotherapy. So I'd like to start by showing a patient of mine. I'm still taking care of the patient. Met the patient a few years ago, a 76-year-old male with initially diagnosed stage 3A non-small cell lung cancer based on having two different nodules in different lobes of the left lung back in 2015. And he underwent surgery, left lower lobectomy and left upper wedge resection, followed by 4 cycles of adjuvant chemotherapy. At the time, we didn't have an option of doing immunotherapy back in 2015 and 16. He was doing well, but then developed respiratory symptoms in 2019, and repeat imaging showed the left pleural effusion and pleural nodules and thickening is seen in the PET scan below. And he underwent a bronchoscopy, which showed the recurrence of lung adenocarcinoma. We performed further testing, and molecular profiling showed PD-L1 expression 50%, and then KRAS G12C mutation. And I'll get back to this case at the end of my presentation. So I will highlight 3 different approaches here. First, I will start by summarizing the data of anti-PD-1, PD-L1 monotherapy, followed by anti-PD-1, PD-L1 monotherapy inhibitor plus chemotherapy. And then in my last section, I'll discuss the double immune checkpoint blockade by itself or in combination with chemotherapy. So the first trial, and this is a landmark trial that I'd like to spend a few slides on because this is a study of pembrolizumab, which is anti-PD-1 inhibitor. And this was significant in the sense that this really changed the way we think about how to treat advanced non-small cell lung cancer without driver mutation. So here in this trial, patients with untreated stage 4 non-small cell lung cancer were included, and then their tumor had PD-L1 expression at least of 50%. And then patients were assigned to either pembrolizumab, which was given initially for 2 years, as long as there was no progression or side effects, or platinum doublet chemotherapy, which was the standard treatment at the time. And the primary endpoint of the study was progression-free survival, and the key secondary endpoint was overall survival. And what was noted in the trial was that the response was better with the pembrolizumab in this patient population. The response rate was 46% with pembrolizumab versus 31% with chemotherapy. And what was also notable was that the duration of response with pembrolizumab was 29 months versus only 6 months with chemotherapy, establishing that pembrolizumab is a better treatment in that sense, but more importantly, it improved how long patient lived. So if the patient received pembrolizumab as their first treatment, patient lived about 26 months versus only 13 months with chemotherapy as the first treatment. And then the hazard ratio was 0.62, and this means that there was 38% reduction in the risk of death if they started the treatment with pembrolizumab as opposed to chemotherapy. The second trial I'd like to discuss is the KEYNOTE-042 trial, and this trial asked this question: can we use pembrolizumab, the PD-1 inhibitor, in a more broader way, expanding the criteria for PD-L1? And remember, in KEYNOTE-024, the PD-L1 requirement at least 50%. In this trial, which is very similar design to 024, the PD-L1 criteria was generous, at least 1%, and patients were either assigned to pembrolizumab alone or chemotherapy. And in this trial, the primary endpoint was overall survival, and they looked at different groups of PD-L1 expression and saw the improved overall survival in the overall patient population defined by PD-L1 at least 1%. However, if you look at the data a little deeply, and especially the PD-L1 expression 1 to 49%, there wasn't a significant benefit of pembrolizumab compared with the chemotherapy. And so in my clinical practice, I tend to use the combination of chemotherapy plus immunotherapy in those with PD-L1 less than 50% if they can tolerate the combination treatment. The next is IMpower110 trial, where the anti-PD-L1 inhibitor called atezolizumab was tested and compared with the chemotherapy. And in this trial, similar findings were seen in those with high PD-L1 expression, defined by PD-L1 expression at least 50% on tumor cells or 10% on immune cells, had a survival benefit with atezolizumab versus chemotherapy, and establishing this as one of the options. And lastly, IMpower1 trial tested a PD-1 inhibitor called cemiplimab, and very similar design study compared with the prior studies where patients were randomized or assigned to two groups of treatments. Arm A was cemiplimab, which is PD-1 inhibitor, and then the second group was the chemotherapy. And in this trial, the hazard ratio for death was 0.57, again, suggesting that there was 43% risk of reduction in death if the patient started their treatment with the cemiplimab versus chemotherapy. And the figure on the right is showing that if your PD-L1 expression number was higher and close to 100%, the better response was seen with the cemiplimab treatment, which is not surprising because cemiplimab is designed to target the PD-1, PD-L1 pathway. So the higher the PD-L1 expression was, the more benefit the patients drove. And this is showing the overall survival. This is updated data presented at ESMO 2022. And then the median overall survival with cemiplimab was 23.4 months, which is pretty close to the data that we saw in the KEYNOTE-024 trial with the pembrolizumab. And the median overall survival with chemotherapy was 13.7 months, and hazard ratio was 0.63, 30% reduction in the risk of death with the cemiplimab compared with the chemotherapy. And with these results, all these regimens were established as a standard treatment by the FDA with the FDA approvals. And really what it showed was that anti-PD-1 or anti-PD-L1 monotherapy has been shown to be superior to chemotherapy alone in patients with advanced non-small cell lung cancer harboring high PD-L1 expression. And moving on to the second section, chemoimmunotherapy. Again, here we are going to review the data of immunotherapy plus chemotherapy. The first trial I'd like to discuss is KEYNOTE-189 trial, where pembrolizumab, again, the PD-1 inhibitor, was combined with the chemotherapy, and then the combination was compared with the chemotherapy alone. And in this trial, where patients with the non-squamous non-small cell lung cancer were included, there was survival benefit seen in the whole study population with the hazard ratio of 0.56, 44% reduction in the risk of death if the patient received the combination pembrolizumab and chemotherapy. And then the benefit is seen in all PD-L1 expression strata, as you can see here in the Kaplan-Meier curves. And the response rate, the tumor shrinkage rate was 48% with the combination pembro plus chemotherapy seen in the table versus only 20% with the chemotherapy. And so the combination not only improved the survival, but also had a better chance at shrinking the tumor. The Keynote 189 that I just discussed was for patients with non-squamous non-small cell lung cancer. Keynote 407 is a very similar trial where they tested the pembrolizumab plus chemotherapy, but then in patients with squamous histology. And in this trial, there was overall survival benefits of patients lived longer with the combination of pembrolizumab and chemotherapy with a hazard ratio of 0.71. And then the benefit was seen in both PD-L1 1%, at least 1% versus less than 1%. And then the response rate was 62% with the pembrolizumab and chemotherapy combination, which is pretty significant, versus 38% with the chemotherapy, again, showing that the combination had a better chance of shrinking the tumor. And an IMpower 150 trial tested a combination of atezolizumab that we discussed in the prior IMpower 110 trial in combination with the chemotherapy and a drug called bevacizumab, which is targeting the vascular endothelial growth factor. And so this was compared with one of the old standard treatment with carboplatin and Taxol and bevacizumab. And then the addition of atezolizumab to the combination of chemotherapy and bevacizumab has shown to improve overall survival with hazard ratio of 0.8, so about 20% reduction in the risk of death by adding atezolizumab to chemotherapy and bevacizumab treatment, and again leading to approval by the FDA. And then IMpower Lung 3 trial included patients with both squamous and non-squamous histology, and then stage 3 B and C and 4 patients. And patients were either assigned to the combination of semiplima plus chemotherapy versus chemotherapy alone, and then the primary endpoint being the overall survival. And in this trial, the combination of semiplima and chemotherapy was superior to chemotherapy alone. Not surprising, because that's something we've been seeing in other trials with the median overall survival of 22 months with the combination versus 13 months with the chemotherapy alone. And to summarize the results of the combination immunotherapy and chemotherapy, what we have shown here was that the chemotherapy plus immunotherapy is superior to chemotherapy alone in terms of overall survival, in terms of how long people lived, and then had higher objective response rate, higher chance of tumor shrinkage in patients with advanced non-small cell lung cancer, regardless of PD-L1 levels. So this is a sort of somewhat versatile regimen where you can apply to many of the patients with different levels of PD-L1 expression. And lastly, I want to discuss the trials of dual immune checkpoint blockade in combination with chemotherapy or by itself. The first trial to discuss is a CheckMate 227 trial where the combination of nivolumab and ipilimumab. So ipilimumab is another type of immunotherapy which targets different pathway of immune system called CTLA-4 molecule, and this was compared mainly with chemotherapy. And in this trial, and now there was a 5-year overall survival update recently published, and in the subset of patients with PD-L1 expression at least 1%, there was continued benefit favoring nivolumab plus ipilimumab compared with the chemotherapy, and confirming the benefit that we saw in earlier result analysis. And the benefit was seen in both non-squamous histology and then squamous histology, as seen on the right. While the approval of the nivolumab ipilimumab was given to those with the PD-L1 at least 1%, the outcome in PD-L1 less than 1% was also interesting in the sense that the hazard ratio, which is a measure of the survival benefit, was pretty good, even in those PD-L1 less than 1%. So in the overall study population, nivo plus ipilimumab, as compared with the chemotherapy, has shown better survival benefit with hazard ratio of 0.65. And then one of the interesting subgroup here was the squamous cell histology group, where the nivo-ipi really beat chemotherapy alone pretty well, with hazard ratio being low at 0.52. And this is a subgroup of patient where I think about using this regimen sort of off-label, though I have to admit that this regimen is approved by FDA for PD-L1 at least 1%. And one of the interesting features of the combination dual immunotherapies, nivolumab, ipilimumab, is that the duration of response is pretty good. If you look at the numbers, ranging from 18 months to 31 months, if you respond to the treatment, and this is one of the important features of dual immune blockade, in my opinion. So the team asked this question: can we use the nivolumab plus ipilimumab in combination with chemotherapy? And here they gave only limited cycles of chemotherapy, only 2 cycles of chemotherapy combined with nivolumab, ipilimumab. And this is trials called Checkmate 9LA trial. And when you look at the overall survival, and this is recent update, the quadruplet combination, nivo plus EP plus chemotherapy, was superior to chemotherapy alone, as this is a theme that we have seen in other trials. So not very surprising, but then again, confirming the benefit of adding immunotherapy to chemotherapy. And then the hazard ratio was 0.74, leading to FDA approval. And then the benefit is seen across different PD-L1 levels. And lastly, and this is the newest kid on the block, Poseidon trial, where the combination of durvalumab, which is PD-L1 inhibitor, was combined with the tremelimumab, which is anti-CTLA-4 inhibitor, and a chemotherapy. And so this is, again, 4-drug regimen versus chemotherapy. And on the right, it's the survivor curves for the quadruplet therapy, durvalumab plus tremelimumab and chemotherapy versus chemotherapy alone, with favoring the quadruplet combination with hazard ratio of 0.77, 23% reduction in the risk of death when patient received the 4-drug regimen versus chemotherapy. And this has led to the approval by the FDA very lately in November 2022. To summarize all the trials that I discussed from the beginning, Keynote to 024 trial to Poseidon, what the trials have shown was that there was significant benefit in terms of overall survival, in terms of how long people lived. And all trials showed overall survival improvement when patient received immunotherapy-based regimen versus just chemotherapy, which was our old standard of care. And so this is a very simple algorithm that I use in clinic, and as very well explained by Dr. Desai and others on the panel, it is very important to rule out or assess for the presence of actionable mutations for which we have a targeted therapy option in the first-line setting. Once we have ruled out that possibility, if we show that and prove that there's no targeted therapy option we can utilize as the frontline option, then I think about using immunotherapy-based treatment options in almost all patients, except for a few minor exceptions. If the patient has PD-L1 expression high, defined by at least 50%, I think there are 2 options. One is to use the PD-1 inhibitor monotherapy, or even we can consider using chemotherapy and immunotherapy combination. And this regimen, the combination regimen, I think about using even in the setting of PD-L1 high, at least 50%, if the tumor burden is high and I want to shrink the tumor as much as possible by with the help of chemotherapy being added to the immunotherapy. For those with PD-L1 less than 50%, I tend to think about using chemotherapy plus immunotherapy combination if the patient is a great candidate for the combination treatment. And we discussed a dual immune checkpoint blockade, and this is something I think about using in certain subgroups of patients. I think we need better biomarkers to identify those patients who benefit from CTLA-4 inhibitor addition to this treatment regimen. So to conclude, going back to the case, this is again, a 76-year-old patient who had a surgery and then chemotherapy many years ago, then recurred with a stage 4 disease with PD-L1 expression 50% and then KRAS G12C mutation. After discussion about different treatment approaches, we opted to use immunotherapy alone, pembrolizumab, given the high PD-L1 expression, and at the time, the tumor burden was not deemed to be very high because the disease was pretty limited in the chest at the time, without any evidence of metastatic disease in the abdomen, pelvis, or brain. And so the patient had a response, if not CR, if not complete response, but almost complete response with the pembrolizumab, and he received that for 2 years. And after discussion, we opted to discontinue the treatment and just watched him. And so recently I saw the patient, before and after baseline, 36 months after initial diagnosis of stage 4 disease. The patient has been doing very well of therapy for 1 year, enjoying his life. And so this was one of the sort of long-term and durable response that I saw with the immunotherapy. Thank you very much for your attention.
Great talk, and thank you, Dr. Kim, for a whirlwind tour of how much progress really has been made. I'd love to invite back Dr. Desai as well, and to start a discussion around some of the excellent questions we've gotten from the audience. And so tying a couple of these together, it's really around molecular testing. And so I'd love to hear each of your institutional approaches. One is around liquid versus tissue, or what's your generalized approach to molecular testing? And two is, are you having any issues with insurance reimbursement, patient cost, financial toxicity related to that molecular testing? And so if it's okay, maybe I'll start with Dr. Desai, and I'd love to hear then from Dr. Kim.
Yeah, I think this is obviously a very important question. Obviously biomarker testing is now standard of care, as highlighted by Dr. Kim as well. I think for the tissue versus liquid approach, I will say historically, obviously before liquid biopsy, good data for liquid biopsy testing started to come out, historically our approach has always been like tissue NGS as standard of care, and it's still the gold standard, considered. But I think, ISLC and other organizations, and I think there's emerging data of this so-called complementary approach, where you would probably send NGS testing both on tissue as well as with the liquid biopsy. There have been instances where you can identify, a targetable mutation on one versus the other. And so I think, using this more as a complementary approach, I think makes sense. And that's something that I'm trying to incorporate into my practice, over the last few months or a year or so. I think in terms of institutional, I would say like most people, when we have a, biopsy where we have enough tissue, tissue NGS, like I said, is still the gold standard. I think the practice varies per providers in terms of whether they send out upfront liquid NGS testing or just send it out, when you have progression after the frontline therapy, and then you're trying to identify these mechanisms of resistance. With regards to the second question, I think that's a question I personally have as well. I try to ask my patients if there were any copays or anything that, was sent to them by the insurance or the vendor in terms of the cost of NGS testing. I think there's really a paucity of data with regards to that. I think that's an interest area actually for me to identify what kind of financial toxicity happens when we're talking with the biomarker testing. I do know that there was a national coverage determination for Medicare that came out, I think now a couple of years ago. So I think that has made things easier. There's data to show that there is actually increased NGS testing since then, but I think it's still not complete, and a lot of work needs to be done in this space.
Yeah, I agree with Dr. Desai. And in terms of my practice, if I have a patient with a newly diagnosed stage 4 non-small cell lung cancer, I tend to use both liquid and then tissue NGS. I know that there's a lot of controversies about how to sequence, or should we sequence, or do you do like parallel testing at the same time? I think the answer has not been fully answered yet, but at least in my practice, I like to send liquid to get the results pretty quickly in about 6 to 7 days, because tissue NGS is probably more comprehensive, incorporating RNA sequencing and things like that, and you can get additional information that way. But then there's an issue of turnaround time. It's not, we hope to get the results relatively quickly, but then sometimes there's various issues that lead to a delay of getting the results. And so in my practice, I use both liquid and tissue NGS.
No, great discussion. We're at the top of the hour, and so we have some excellent questions. We'll actually have the opportunity to ask him to not only Dr. Kim and Dr. Desai, but the wider groups. I'd like to invite back Drs. Leal, Iyengar, and Ratau if they're available, and we can go through some of the questions that I think are more broadly relevant, and would love to hear from folks. And so. Here, I'm going to fold in two questions and would love to just kind of round robin here what folks do. And Dr. Iyengar, I know you know this stuff anyway, so feel free to chime in on the med-onc questions at least as well. And so the question I'm going to merge is a couple, and that's, what is your standard of care for a patient with no driver actionable mutations and a PD-L1 score greater than 50%? So basically, what do you think Insignia is going to tell us in that cohort? And then relatedly, do you do anything different if PD-L1 is stone cold zero on a reliable biopsy? Are there any problems with, chemo pembro or chemosimilimab or whatnot? And so maybe we'll go round robin, at least from my screen view, starting with Dr. Kim.
Right. So for PD-L1 high, at least 50%, I tend to use immunotherapy, monotherapy, PD-1, PD-L1 inhibitor, such as pembrolizumab, unless I think that the patient has a high burden disease. That's somewhat subjective. I had to acknowledge that because when there's a big tumor sitting near the critical structures, I want to shrink it as much as possible. So then I use the combination of chemotherapy and immunotherapy, even in the setting of the PD-L1, at least 50%. PD-L1 negative, like 0%. I use chemo plus immunotherapy. I found the data of nivolumab, ipilimumab in PD-L1 negative and then squamous histology very interesting and probably the best hazard ratio out there. And so I think about using sort of nivo-ipi based regimen for those specific patient populations.
Yeah, I think that's a great point. From my own perspective, we have no firm data, right? So we just have to deal with the data we have and the subgroups. And for me, it's basically saying, what's your favorite topping on a pizza, right? There are very few bad choices except pineapple. Then we got to avoid the pineapples. But really, the question is what to do. And so for me, for PD-L1 greater than 50%, my null hypothesis is actually chemo pembro, or I guess chemosimilimab would be quite reasonable as well now. But the general idea that if you look at the curves, there's a little bit of crossover early on for patients who get IO alone. And I can't always predict who they are. Often they're STK11 keep one, maybe lower tumor mutational burden. But if a patient can tolerate chemo, they're getting the IO along with it. And so for me to kind of hold the chemo part for a PD-L1 greater than 50% patient, they need to really have low volume disease, maybe be a poor chemotherapy candidate. And then for PD-L1 less than 1%, I consider anti-CTLA-4 approaches just based on some of the subgroup data. You'd have to do that with chemotherapy, for example, Checkmate 9LA or Poseidon. There's no cross-trial comparisons there. It's just the durability of response for PD-L1 negative patients approaches that of patients with low PD-L1 positivity. And so if one does think about CTLA-4, which I do, I generally consider for PD-L1 negative, it's not a wrong choice to give chemo pembro, especially with Keynote 189, where the data looks really good in non-squamous. But if you look at the squamous data, it doesn't look particularly good for PD-L1 negative patients. It's a smaller subgroup, nothing wrong with it. So I think we have more questions than answers, but we have to make decisions in clinic, and that's just my mental model and how I think about those. Love to hear, Dr. Desai, how do you handle those two cohorts in your clinic?
Yeah, I think the practice is quite similar. I think, like you mentioned, PD-L1 more than 50%. Really, I think default is chemo IO, and I really try to find reasons or identify if there are any reasons not to give chemo, which may include performance status, tolerability, and maybe low tumor burden of disease. So, and then for the negative, I agree with you. I think I try to identify factors which would probably lean me towards an anti-CTLA-4 based regimen. Although I will say that I think the dual checkpoint with the adverse events that I've seen and anecdotally in patients, I I think that is something that we have to very carefully consider because with the anti-CTLA-4, there definitely is, increased risk of immune-related adverse events. So that's something that I kind of, check in more.
Dr. Leal?
I don't have much additional data to sort of, or opinion to add to this. I do strongly consider, clinical factors, patient preference, and certainly the impact of co-mutations. And also thinking about clinical trials, although this is a space, as you said, that we have a lot of options, given the unanswered questions and subsets of patients. If I have a good clinical trial, that may be an opportunity that's interesting for a patient, I'll certainly always consider that and discuss that with the patient and their family.
Dr. Ratau?
Yeah, no, I agree with, I think, a lot of what's been said. For PD-L1 high patients, my default is actually IO monotherapy, and I need a reason to add chemotherapy because I'm adding toxicity with that regimen. And why I might add it: one, patients with symptomatic high disease burden where the stakes are really high. I need a response to this first treatment. I'll go chemo IO because it gives you 2 shots on goal to some extent. The other reason I might do it is, PD-L1 high is not one population. PD-L1 50% is probably very different than PD-L1 90%. So the higher that PD-L1 score, the more likely I am to jump to monotherapy. And the lower that score, 50 or 60%, I'm probably more likely to be leaning towards more easily adding chemo into the regimen. For PD-L1 negatives, I'm not treating them differently right now. I do chemo IO without the CTLA-4 additions. I think it adds toxicity. And again, I'm not sure. We have subgroups, but that's tricky and no direct comparison. So I'm watching that data very closely, but not acting upon it just yet. And I think the real answer is for all of these populations, if you can find an appropriate first-line clinical trial, that can be a great option.
Great point. And Dr. Anger, the age-old question, holding treatment during radiotherapy, whether it be SBRT or SRS, any pearls or high-level evidence on what we do for chemo IO strategies versus targeted therapy strategies, or what's your practice?
Yeah, there is not a lot of high-level evidence that's asked that specific question. We hold TKIs for a few days before and till a few days after the delivery of radiation. There is some suggestion that there could be increased lung toxicity through, and so we don't. We're a little bit less certain about doing that together. And certainly chemo IO we hold for at least on all the trials for the radiation to be delivered, and then we restart it. I think what's going to be very interesting. We've treated a lot of patients. What's going to really be interesting is whether the patients that got chemo IO versus monotherapy, IO monotherapy, they had a different toxicity profile. If they've gotten local consolidative therapy, I think you're going to see that there is going to be a difference in a toxicity, and whether that's going to play a role in how aggressive we are with the local therapies.
Great points. We've gotten several questions while we were answering that question. So in the interest of time, maybe I'll direct these as much as possible. Maybe starting with Dr. Ratau. Recently, there's an FDA-approved neoadjuvant Opdivo regimen for non-small cell lung cancer. You discussed this in your talk, Check Me 816. How would this affect this patient says, my treatment plan, I'm going to envision someone who's probably already had surgery. Would you use Opdivo in the adjuvant setting? Would you use atezolizumab? In what context would you consider integrating immunotherapy for someone who's already kind of started their journey?
Great question. So, we have both options, preoperative or postoperative. The key thing is I'm not doing both right now until I have some approved regimen that includes both. So I'm choosing one or the other. So if I meet a patient pre-op and it feels reasonable to give immunotherapy, I'm giving chemoimmunotherapy first, sort of as my default. But you're also still in a fine situation if you've already had your surgery. If you're PD-L1 positive, you have that option for that 1 year of adjuvant atezolizumab, which is another immunotherapy drug like nivolumab, or Opdivo, as you referred, which is the brand name. So you can still do that 1 year of adjuvant or postoperative immunotherapy. And I'll routinely include that for my PD-L1 positive patients who haven't gotten it pre-op already.
Great. For Dr. Leal, after 2 years of alectinib, the question here is around a solitary osteolytic spot in the spine. Is this progression for a solitary progression? Can they see on the drug? Is a change in TKI needed? And then for Dr. Angar, what is your thinking around treatments of oligo bone metastases vis-a-vis visceral? And so maybe we can start with Dr. Leal.
For the patient who's doing well on alectinib and has, tolerated it well, I would confirm this is a site of a oligometastatic progression, doing PET-CT and further imaging of the brain, making sure there's no CNS progression. I would then talk to Dr. Iyengar about, hey, can you ablate this lesion and continue on the alectinib, and certainly keep close eye and monitor the course and patient symptoms following radiation, but would continue on alectinib, and that would necessarily trigger an immediate switch, although would have that discussion that perhaps we are, at the point of requiring switch in the future.
And I concur. I think, we know, I think as a field and as patients that, every subsequent line of therapy may be a little bit less effective than the previous line of therapy. So whatever we can do to maintain the patients on the current line of therapy, I think is the best resource. So we are happy to treat bone mets. We're happy to treat visceral mets. We're happy to treat brain mets, as long as we think that there is a rationalization of keeping the patients on the systemic therapy. Now we have to look at the kinetics of subsequent recurrences. If the patient has 5 more mets in a month, then probably the local therapy was less than ideal unless it was for palliation. But if we can get 6 months, 8 months, 10 months, I think that's really the way to go. Again, we can't predict. So right now we're probably opting to give the patient the benefit of the doubt and treating with local therapy.
Great points. A couple more questions have come in. I'll make sure to get through many of these as possible. Dr. Desai, for stage 4 non-small cell lung cancer with high PD-L1, but a atypical mutation, let's say, EGFR that's not described or a VUS, would you, or maybe a point RET fusion, I'm just throwing out some specifics to try to flesh out this question. Would you favor targeted therapy for not perfectly defined, but still gene relevant directed therapy? Would you favor chemo alone? Would you favor chemo IO? Or how do you think about those mutations that don't quite fit into the clinical trial schema for what we're enrolled, but could potentially be sensitizing?
Yeah, I think that's a great question. I mean, I would probably consider it, but only in later lines of therapy. If I have more definitive evidence with a high PD-L1 to go with the immunotherapy backbone, I think I would probably go with that. And also it depends on case by case basis. I can envision that, you may have issues with reimbursement if you're trying to use a targeted therapy, which is kind of outside the scope of approval without any good evidence, even, in other studies, even if it's not FDA approved. So I would probably approach it with an immunotherapy backbone, with the fact that there may be, when we go to the second and third line and we're kind of having to find options, I think then, definitely something, if at that stage, it makes sense in terms of tolerability and, with the disease burden and things, I think then maybe, willing to try that targeted therapy.
Great points. Dr. Kim, there's a question about every 6-week dosing of pembrolizumab. Is this something you've adopted in your practice? Is it universal, subset of patients? What are your thoughts on extended interval dosing?
Right. So the every 6-week dosing was something I was using quite a bit when we are at a sort of, when we are having a lot more COVID cases than now, thank God. And but now I have switched back to every 3 weeks for most of my patients. And there's some data, comparing the every 3 versus every 6 in terms of side effects. And, some say that every 6 may have a little more side effects, but then one of my rationale to keep everybody see patients every 3 weeks is that I can keep an eye on things a little closely, because every 6 weeks you can, things can get sort of lost in the and in terms of close follow-up. And so my practice has sort of returned back to every 3 weeks. But in some patients who have been on pembrolizumab, every 3 weeks and has done very well without very minimal side effects, I discuss every 6 weeks still as an option.
Great. Dr. Angar, for oligo progression to the pleural area, and I'm going to assume this question has to do with non-small cell lung cancer, would local therapy directed at the pleura be a good option in the oligoprogressive setting?
Yeah, I mean, it's a really good question. We do not traditionally include patients with pleural effusions, for instance, meaning, the disease has got into the pleura for the clinical trials that most people are doing. But if the patient had a pleural effusion up front, the pleural effusion has resolved and they meet the criteria for the trial, then patients are included for good or bad. I think for a pleural specific metastasis, I have no problem radiating that with the caveat that it has now, those cells have access to the pleura and it could disseminate a little more rapidly distantly. But I think it's a very much a possibility. Sandeep, if I may, a patient did have a question about how to enroll on clinical trials for this setting. It may be easiest if I can answer that from Maria, and Maria can get in touch with that patient because I can try to direct the patient as best as I can.
No, I think that's a great great option, and so we'll follow up offline on that. But I think clinical trials they bring the latest care to our patients, and they help inform the next generation of treatment. And so we want to contribute to those. So thanks for that, Dr. Leal. We have a patient who has side effects from neoadjuvant chemo IO, mainly mouth sores and fatigue. Any advice from supportive care we could provide them?
So mainly fatigue and mouth sores.
Mm-hmm.
Yeah. So I think, fatigue is a challenging one to manage in real time. It depends on the severity of the fatigue. Certainly in situations where both the fatigue and the mouth sores are severe enough that it's impacting hydration, nutrition, a dose hold, meaning not giving that chemo IO next cycle, would be warranted, and perhaps delaying it by a week until further recovery. Additional things that can be used include IV hydration in the infusion clinic, can also be another option. And then for mouth sores, a lot of time we use topical medications for pain, topical lidocaine, topical steroids, mouthwash that can be helpful. And then lastly, dose reductions could also be employed to make the next cycle more tolerable.
I think that's a great point. And really some good pros. I've had a lot of success for my patients with topical steroids, as you mentioned, Dr. Leal. And then, with fatigue, as you mentioned, it's really complex. It could be chemo, but now with chemoimmunotherapy, could it be thyroid, endocrine? And so thanks for highlighting those points. Dr. Patel, what would be your next steps for a 65-year-old woman with non-small cell lung cancer, no actionable driver mutation, low PD-L1 with progression on a Keytruda or pembrolizumab containing regimen?
Yeah, so it depends, I think, a bit on what was given. So Keytruda alone, the standard of care option is to go on to platinum doublet chemotherapy if you haven't gotten that up front. And that can be a great option, especially for adenocarcinoma, it's carboplatin, pemetrexed. That can be a really well-tolerated regimen. Now, if insurance lets me get away with it, I will sometimes add that into the Keytruda if I think there's been some benefit, or I'm not sure if there's been benefit from the Keytruda or pembrolizumab. I should use the generic name. So sometimes insurance doesn't let me do that because there's not technically data, but I'll try to get it if I can. If someone's been on chemo plus immunotherapy, then that's a situation where I'm definitely thinking if I can find a clinical trial, that's a great time to find a clinical trial because there are some interesting studies looking at adding novel immune modulators to people who've developed resistance to initial immunotherapy containing regimens. Absent a trial, we're looking at other single agent chemotherapy drugs, which can be beneficial, but maybe aren't as beneficial as we wish they were. So it's always a great time to be thinking, is there a good trial?
And as you nicely summarized, clinical study are synonymous, at least for our discussion points. And to wrap up, I'm going to bundle a couple of these together. Dr. Kim, what are your best strategies or advice on either treatment limitations or imaging limitations that often are imparted by insurance? Any pearls that we can share with our audience? Sadly, something that we have to deal with in the real world.
Right. This is a very important area. And I have had several patients who didn't get timely treatment for their lung cancer because of lack of adequate insurance. And then oftentimes, even if they apply for Medicare or other types of insurance plans, it take a long time and really delaying their sort of life-saving treatment. And so I think that this is something, we need to address as a society. This is really a societal problem at this point. And I think you're losing patients because they don't have the adequate insurance, and then therefore they cannot get treatment. I have had several cases where sort of approval of certain drugs that I requested from insurance companies were sort of delayed because of there's a peer-to-peer, there's different sort of barriers, and we all struggle with that. And I think there is many stories out there. And so this is a sort of daily struggle. And I think in order to approach this, not only one organization or one person can deal with, but I think we can all work together, different organization, patient advocacy, government. And this is a really an important and a very serious problem at this point.
Absolutely. And in terms of working together also, clinical trials can be found at clinicaltrials.gov. It's required that these be registered. That said, the site can be unwieldy. And so talking to your doctor can be very helpful there in terms of what may be the best approaches. And so with that, I really want to thank Drs. Kim, Iyengar, Ratau, and Desai for joining us today and their excellent talks and answering really a really impressive set of questions that run the gamut of the state of the art in thoracic oncology. Also want to thank my friend and colleague and co-host, Dr. Leal, who can help us close out the meeting. Thanks, everyone.
Great. Thank you, everyone, for joining us today. We are so glad that you all joined us and made excellent contributions to our panel discussions. So thank you to the presenters. Thank you to Grace. And I'd like to thank our sponsor, Takeda, and hope you all have a wonderful holiday season with your families. Bye, everyone. See you next time.